circumstance that occurs after birth. But the majority of times, intellectual and developmental disabilities are diagnosed within the first few years of life, are lifelong disabilities, and typically are attributable to physical learning, language, and behavioral impairments. As such, they have impact on ADLs, on IADLs, but all depending on the level of disability and level of cognitive limitation. There are some people with developmental disabilities who have no cognitive limitations at all. And so a lot of times you'll see, I was talking to a friend the other day who has a daughter with Down syndrome who's in her 20s, and for all practical purposes really has very limited very little cognitive limitations, to the point that when she was going through school, she could not get into the special education program because she's so advanced in her thinking and her social abilities. And so there's a lot of variation, so I don't want to treat this as if it's a homogeneous population. That's actually part of my research agenda. The most common types of intellectual disability that people are aware of are just straight on intellectual disability, what unfortunately used to be termed mental retardation when I was young, but we've fortunately gotten rid of that word and typically use just intellectual disability in this country. Cerebral palsy is considered a developmental disability, as well as Down syndrome. More recently, the CDC has added ADHD to the list of developmental disabilities. There's some discussion about whether that sticks or not, but at least for now, you'll see that. There's a lot of difficulty just up front for those of you who are not aware of my research or this area. The biggest problem, the biggest limitation across the board is the data. We do not do surveillance on this population in the US, especially after folks leave the educational system, so after they graduate from high school. Prior to leaving the educational system, I'm not going to say we do thorough surveillance because it's not formal health surveillance, but we have a better idea of how many people are in the child population that have a developmental disability. And estimates right now, they're running high. They're running between 9 and 12%, but a lot of that is because the inclusion of ADHD, but also the increases we've seen in autism diagnoses over the past 10 to 15 years. And so our guess would be that you don't have as many folks with intellectual and developmental disabilities in the adult population, but there's just really no true way to tell. The estimates that we do have are from the National Health and Review Survey, and the majority, all but one, come from the 1994 to 95 NHISD, which only covers the non-institutionalized population. So it necessarily misses folks whose level of disability is severe enough that they're requiring full-on medical care within some type of state hospital or institution. And so in and of itself is going to be biased only towards those with more mild or moderate forms of disability. But the estimates there are about 1.49% of the population, which if correct, and I think we could quibble with that, would be about 4.9 to 5 million within the current population of adults in the US has an intellectual and developmental disability. So it's a sizable population. The difficulty is we really just don't know how sizable it might be. The other problem is even when we do have, like the National Health and Review Survey ask a direct question, at least it did. They dropped this in whenever it was, 2016, 17, I don't know when 19, when they did the redo. And they dropped the direct question about intellectual disability. Many of us advocated that they did not do so, but it's apparently gone now. But even when you ask a direct question of adults around whether they do or don't have an intellectual disability, there's going to be a bias again towards more severe levels, because individuals with really mild intellectual disabilities and no other physical impairment, once they leave the US educational system, typically leave that label behind, especially if they are living a life like anyone else. They're getting married, they're having kids, they're getting a job, and their disability the impairment that they had that actually was disabling within the school setting maybe is not once they get out and are working and just within the community. And so even when we do have samples of adults within nationally representative data, I think it'd be really tough to say that they truly represent the full population. Typically and historically, disability and health have been conflated. Going back, even if we get into literature from the 50s and 60s, where disability was considered a physical health condition. And so through the 60s and 70s, with some of the necessary upheavals that occurred within society, disability advocates pushed back to say, no, what we experience through the impairments in our body are not physiological health problems. I mean, they don't cause us necessarily to be ill. And the real push here among the advocates was to say, we can be quite physically healthy and still have a disability. What really informed some of this theoretically over time was what is termed the social model, which recognizes that within the social model, that disability and impairment are seen as two separate things. That a person can have an impairment that means they might have reduced cognitive functioning, they might have they might have some physical limitations, but that the disability that they experience is not from the impairment, it's from the way that society is structured. And that if society is structured in such a way that excludes people with particular types of impairment, I mean, the real simple model would be is if you have a building with just steps and someone is a wheelchair user, the impairment of using the wheelchair is not necessarily impeding them from participating. The difficulty in participating is because of the way the building has been structured, and it can be remedied. And so the social model did a really good job of pushing away from seeing disability as a problem, or the problem, I'm sorry, for health, and separating the two. And the way that the social model would articulate it would say that disability is not a problem, underlining not at all, meaning that it is not a factor within health in any way whatsoever. Some folks, and I include myself in this category, have pushed back a little bit on the social model to say it's really good to understand that the difficulties, discriminations that folks with disability experience are not due to impairment, but are due to the way that we structure society. But to recognize that there are some impairments, disabilities that actually can be a problem for long-term health, meaning that they can lead to increased prevalence of other diseases, or in and of themselves, the physiological difference that within the bodies can actually cause long-term health problems. And so I'm thinking, like, for instance, if you think about someone with Down syndrome is going to have low muscle tone around the mouth and around the neck, which can lead to dysphagia and choking, and increases the risk of pneumonias and pneumonitis, kind of long-term infections within the lungs. And so that's something that can't necessarily be fixed by changing society. And so the way that the person's body has been formed is actually going to increase their health risk and possibly lead to earlier death. Another thing, and Down syndrome again being the case, would be congenital heart defects, or also what we're seeing is the really early onset of Alzheimer's disease among folks with Down syndrome. That the research that we just put out shows that it starts actually in the 30s is where we begin to see some peaks. And by the time we hit 40s and 50s, you've got sometimes 60 to 70% of this population that has developed Alzheimer's disease. So this is why I want to push back and say that disability is not the main issue, but it can, in some instances, be a problem for long-term health. The difficulty, though, is even if we try to strike that balance of saying, okay, the way that we construct society can actually lead to difficulties and health problems for folks with disability, but also the impairments that folks have can also in and of themselves lead to increased prevalence of disease or difficulties with health. That no matter what, that within the medical community, there still is the tendency to conflate disability and health. And the term that we use when we talk about this is diagnostic overshadowing. If you've heard this, it's probably, if not around disability, been related to discussions of mental health diagnoses. And what happens, like with diagnostic overshadowing, I was reading a case the other day in a journal where, like, you had an individual with intellectual disability who came in moaning and yelling and complaining into the doctor's office and had been doing so at home with the parents. And the parents said, "We don't know what's wrong. Please help. There's something not right here. Our child is moaning and yelling, and we don't know what to do." And their child was someone who did not communicate readily. And so the physician had diagnosed the child with a behavior problem and gave them some psychotropic drugs in order to calm them down, and said it's just part of their disability. They're reacting. Well, what was going on is their bowels were impacted. And the moaning and the yelling, which many of us would do if we were in that situation, was due to a physical problem. But the diagnostic overshadowing that the physician actually engaged in was to label everything that's going on here as part of the disability. And we see that quite frequently within this population. I'll talk about this a little bit more when I get to the death certificates. It's a vulnerable health population. I mean, the history of maltreatment parallels some of our most marginalized groups within society. If you think about mass institutionalization that occurred in the 30s and 40s, and then we get into the forced sterilization laws that were on the books in the early 1900s and increased for this population into the late 70s, where without question, if you had a cognitive disability, you just were sterilized. And then also continued ableism and underfunding of support, which will become a real issue with the post, or well, I don't think we can say post-pandemic, but the economic downturn that we're going to experience with the pandemic, where states are now beginning to across the board cut budgets by 25% for disability providers, saying you're just going to have to deal with it and make do with it. We're going to cut funding. So this is a population that very easily gets pushed to the side. It's a small group. It's a group that hasn't really had voice within power structures. And so because of that, we see difficulties also within the healthcare system. Cron talks about a cascade of disparities where for years it was just access to care. Access to care has increased over time, but quality care really has not. Much of that is related to provider training. I mean, medical personnel a lot of times don't have exposure in training or even in practice to folks with intellectual and developmental disabilities. And so when you have someone come in who has some communication difficulties, they just don't know what to do. And the easy thing to do in moments of not knowing or moments of uncertainty is to simply default everything to, well, this could be the disability, because they're just not quite sure how to communicate with this population. Very high level of underrepresentation within research. And then also, like I said before, but is becoming increasingly an issue we see during COVID, just no surveillance within this country. And this is atypical. If you look in a lot of developed nations, they very carefully surveil folks with intellectual and developmental disability, typically through primary healthcare providers. They, through the PCPs, they'll create registries that will follow these people across their life course. And so we see, and I'm in touch with folks like in Sweden and in the UK and in Denmark, who are very carefully able to track what's going on with this population during the time of COVID, where here in the US, we're just really struggling even to get a handle on where people are and what their experiences are during this time. All this together, this broad package, and so disability possibly leading to higher prevalence of certain diseases, maybe of certain types of infections, the history of discrimination and marginalization, the continued difficulty with quality of healthcare has resulted in some pretty severe mortality trends. And for mortality, what I'm looking at for death is looking at age of death. We can't do life tables. We don't know population size. And even when we have death certificates on this population, we can't be sure that we've got a death certificate for everyone who died in a certain year who had a developmental disability, because there are many instances where a certifier may choose not to record this disability on the death certificate. And I'll talk about that a little bit later. And so just as has been done with HIV research or also with sickle cell research, I mean, we're kind of stuck with looking at age of death, differences in age of death at times. So it's not the best case scenario, but it's the most reasonable way to kind of get a handle on what's going on. If you look historically in the 30s, the typical age of death for this population was 20 years. By the 70s, it was up to 50 years. And then by the 90s, and people have really celebrated this, it was 60 years. I mean, this was like, I remember I was doing direct services during this time, and we were just all amazed, because it's like, this is the first time that we're seeing part of this population make it to old age and actually began to think about what does retirement look like. Whereas prior to that, retirement wasn't even an option, or that, older age wasn't an option. You just assumed that people were going to die in their 40s and 50s. So this was something that was really, it should have been and has been celebrated. And the increases over time have commonly been attributed to improvements in healthcare, in education, in the shift. I mean, we did this real shift where we closed down institutions in this country in the 60s through the 80s. And folks transitioned to living in the community, and it's really improved people's health. because they're able to get out, they're able to work, they're able to have friends, have social supports. And as that has occurred, we've seen these shifts in this population. So this is the good part of the story. This is the beneficial part. There's some problems, though, with the research, the prior research on age at death among folks with intellectual and developmental disability. The first being is that it treats folks with this type of disability as a homogenous group. And so if you look at like articles from even as recently as the 90s, and they're talking about the age of death for folks with intellectual and developmental disability, it's throwing everybody in together. And so it's people with an intellectual disability, with Down syndrome, with cerebral palsy, with fetal alcohol syndrome. I mean, all of them are just grouped in together as if they have similar life courses, similar health issues, similar experiences, which is just not the case. And then the other problem that we see is there's been no evidence since 1990s. Okay, so folks made it to the 60s. Is that the best that we could do? Or is there a chance that folks with this type of disability are actually living longer? And so this is what I want to show you, some research that we've been doing recently first, just to give you an idea of what we're finding. First is regarding not treating this as a homogeneous group. And this is from a recent paper that we put out where we looked at age of death for adults with intellectual and developmental disability. And this is this was 2012 through 17 US death certificate data. And so the average age of death for folks without any type of intellectual and developmental disability was 75. But you see the difference by type of developmental disability. So the group that was doing the best were those with an intellectual disability but no comorbid other developmental disability. So this would be intellectual disability but no Down syndrome, CP, nothing else on their death certificate. And this population at that time was living into their early 60s, average age of death. We actually saw some people, there were quite a few people around 100, 110, which was just unheard of, like I said, for this group. Then folks with Down syndrome were living into the mid 50s. And then people with cerebral palsy were living average age to right around 50. And so this is one of the first things that we wanted to kind of tease out and say, okay, we got to quit just lumping this group together and saying, oh, average age of death is 60, when it's not. It is for folks with intellectual disability, but not for folks with Down syndrome and cerebral palsy. So there's much more room to be made up here, and to pretend like this is everybody together just is misrepresenting what's going on within the population. And so the question that we've had is what's driving these age of death trends? And obviously the reason we're asking this is, can it be reduced? If you've got, this gap here, that's more severe than what you'd see between blacks and whites, between men and women. And so it's a age of death disadvantage that we need to address. The question becomes how much, how much of this gap can actually be made up? Or is there an inherent disadvantage related to the impairment? There may be to some extent, but I don't think we've topped out on any one of these. And so our hope would be, can we try to figure out what would actually increase age of death for each one of these groups? The first thing I'm going to look at is, in the presentation today, is year. I'm not going to do as much with biological sex, but maybe a little bit, I would do some with race, ethnicity, and state differences. So this recent paper that's getting ready to come out, this is looking at the changes over the past 10 years for this population. So what we were trying to understand is this gap continuing to be reduced? Are we still seeing improvements in age of death for folks with intellectual and developmental disability? And we are. The general population without any IDD increased a little bit. We see it was about a half a year age increase over this time period. But we see more substantial increases for folks with intellectual and developmental disability and some decrease of the gap. And so those with ID going from 60 to around 64, those with Down syndrome from 54 to 57, and those with CP from 50 to 54. And so this is the first thing we've tried to get across in this research. It's not just that we can't lump these folks together, but that we actually need to look at changes over time to see if there's consistency or inconsistency. The real question in my mind right now is what's going to happen in 2020? I'll get to that maybe a little bit later with the COVID, is are we going to see excess mortality in this group that we don't see in the general population? I think we probably are. And how will that set back these gains that we've seen over time, or is there a chance that we can maintain some consistency there? So the next question that we're looking at more now is, are there state level differences? And these next few slides I've pulled from a website that I've been putting together where we're trying to highlight kind of state differences in patterns of age at death for this population. And so these are just basic QGIS stuff. On the website, when you hover over the state, you actually get the age at death within that group. But I've just got the quartiles here to the right, and the quartiles will change for each slide. But you see some patterns that are not dissimilar necessarily to the general population, but that do seem to show some trends. And the one that you'll see consistently over the next few slides is this portion of the country, the Midwest, the Dakotas, Wisconsin, Minnesota. The age of death for folks with intellectual and developmental disabilities, and also in the Northeast, is actually typically higher than the rest of the US. And the part of the US that's doing the worst is typically going to be seen in not just the southern and southwestern states, but also in the western southern states. California, interestingly, is not doing well in any of these slides, but they've also cut their funding pretty severely for supports for this population. So this is folks with intellectual disability. This is folks with cerebral palsy. I mean, you can see just the real change where the southern states are just really not doing well at all, but you still see the consistently higher ages of death in these Midwestern states and also in the Northeast. It's a little bit more of a patchwork quilt for folks with Down syndrome, as we see Texas, Florida, and who is that, South Carolina and Tennessee seem to be doing a little bit better. You still have this general southern trend and general, Midwest and Northeast, but we see a few states in Alaska as well doing better for folks with Down syndrome. Down syndrome is really I'm not going to say it's unique, but compared to folks with a child that's born with an intellectual disability, there's a good chance it's not discovered if they don't have any other comorbid disabilities until school age. Or maybe even if you've got really perceptive parents, maybe around age 2 or 3, when the child is maybe not meeting developmental milestones. But for a lot of these folks, it's not till they get into school that the realization is, oh wait, there's some challenges here to learning, that an intellectual disability is diagnosed. For many people with cerebral palsy and Down syndrome, this is from day one. There are characteristics that physicians can pick up on to say, okay, we've got something here that we need to attend to. And so the reason this matters, especially when we start getting into state policy, is for folks with cerebral palsy and Down syndrome, early intervention can start at day one. Whereas folks with intellectual disability, early intervention typically doesn't start into age 4 or 5. And so you've got that lag time of those early developmental years that have kind of been missed. That is also, I think, one of the reasons we see the increase in autism is there's a lot more funding for early intervention for autism. So if you've got a child with an intellectual disability and you can get the physician to convert that diagnosis to autism, what we're seeing, and parents will actually say this, is if I could just get the autism, there's more funding and more opportunity to get the even preschool age to get interventions. So the question that we've been trying to look at is, okay, can we explain some of these state level differences in age of death? And just like there's limitations in just the data overall, there's also going to be limitations in the type of state level data. However, there's one group out in University of Colorado, Boulder. David Braddock started this back in the 60s. It's called State of the States and Developmental Disabilities. And what this group's been able to do is every state in the US, and this is voluntary, but they've been able to twist their arms and get them to do it for 30 or 40 years. Every state in the US reports the amount of money they have spent on intellectual and developmental disability services over the past year. And they report this, they put their report out about every 3 or 4 years. And so the reporting by the state is how much money, it's typically into 2 categories, how much money the state has spent on institutional services. And these are typically services they used to be state hospitals only, but now they can be kind of pseudo hospitals, maybe nursing homes that just have folks with intellectual and developmental disabilities, but they're always 16 or more beds. I mean, we don't have as many of these institutions across the US, but there still are, there's some states like California that don't have any at all. They got rid of all their institutions, but there are others like a lot of these southern states, Mississippi, Florida, South Carolina, who still maintain 3 or 4 institutions And we say 16 or more beds, but it's just important to realize that what you're typically talking about is 400 or 500 beds. And so it's large scale institutional care, nursing care. Sometimes it's people who really need medical care. Sometimes it's just people who, for whatever reason, don't have the family support, have not been able to live in the community. Maybe have gotten in trouble with the law, maybe have had some behavioral issues, but have just gotten tracked into, they can't make it in the community, and so they stay in an institution. So the states report on how much they spend on that every year, and they also report on how much they spend on community spending. And that can vary from residential group homes to how much they're spending on early intervention services for young children, but just the overall lump sum, how much they spend. What the state of the states does is so that you can use this as a comparative measure, the way that they standardize it, and the data that I'm using is their 2017. The data goes from 72 through 2017, but they've standardized to 2017 dollars. And they do IDD spending per $1,000 aggregate state personal income, which their argument is that this is a way to control for differential wealth across states. I mean, I think we could argue about that. But it does give you some type of standardized measure or way to compare state spending over time and across states. And so what I've done is, when we're trying to look at how changes in state spending might be determinative of differences in age of death, I've looked at the 10 years prior to the death. So I've got death certificate data from 2005 to 17 with the geographic markers. And then I've combined it with the state of the states data. And so if you died in 2017, I've looked at the average state spending from 2007 to 2016 in the 10 years preceding your death. So I didn't want to just capture at the time of death. You want to capture obviously some time before to see if it's had some type of effect. There could be, I guess there could be some concern about people moving, but what we know from research is folks with intellectual and developmental disability move much less, especially from state to state, than the general population, because if you receive services from a state, you're kind of locked into the state. So like if I were to be receiving services to cover costs to live in a group home with 4 other folks with intellectual disability, typically it's through a Medicaid waiver, it's fed in state dollars matched. But if I'm doing that have that in the state of New York, and I decide, or my family decides, we're going to move to New Jersey, I give up my waiver in New York, and when I go to New Jersey, I'm now on a waiting list, which I would have to wait sometimes 2 or 3 years to get those services again. And so because of that, individuals with disability and their families are typically locked into a state. They don't move as much. So just all to argue that I think these state level measures, while they might not be accurate for everybody, for the majority of people within this population, I think the 10 years prior would have some impact on health. So these are early preliminary results. And what I've got graphed here at the bottom is the spending. So the amount of dollars spent per $1,000 of aggregate personal income for the state. And on the left is the age of death. And what really showed up here, and this wasn't surprising, it's a report that we're working on now, is because we knew there were differences by race, ethnicity among folks with disability. More pronounced, and you'll see that in a second, among those with cerebral palsy, but similar to the general population among those with intellectual disability, a little reduced for those with Down syndrome. But what we're finding is that state spending on, and this is for community services, state spending on community services for folks with intellectual and developmental disability is benefiting non-Hispanic whites with intellectual disability, but is not benefiting any other racial ethnic minority groups. And so non-Hispanic Blacks, Hispanics, and non-Hispanic others are either not benefiting at all or actually showing reduction in age of death over time. This yellow line, I've got to tease this out more. I was playing with this the other day. I don't have it here, but this is really being driven by non-Hispanic Asians. And this is something we're trying to figure out in our literature, is non-Hispanic Asians across every intellectual and developmental disability group are experiencing a much greater racial, ethnic, age of death disadvantage than any other minority group. And I'm just right now puzzled about that. And so like, say you have expected differential of, 6 years for non-Hispanic Blacks, or for Hispanics, maybe 7 years. It'll be similar to that. But for non-Hispanic Asians, say you're expecting a 4-year difference. Once you get into the disability group, it's like a 14-year difference. It's like a major disadvantage that we're seeing. So I've still got to tease that out a little bit. This is a similar story for those with cerebral palsy. Non-Hispanic whites are benefiting as far as the relationship between community funding for state services and age at death, but the benefit is not accruing to the racial ethnic minority groups. And it's a little different for folks with Down syndrome. We saw the benefit for non-Hispanic whites and a little bit for Hispanics, but it was not for non-Hispanic Blacks. I mean, it shows an increase a little bit, but it wasn't significant, or for the non-Hispanic other group. And so, like I said, this is preliminary. We're still teasing this out. I'm going to be adding in I've got a couple of other measures. One's from RISP, I don't know what RISP, University of Minnesota. Sherry Larson collects data on residential placements of folks with intellectual and developmental disability within each state, like what proportion of this population is living in large-scale institutions, and then among the community settings, what proportion is living in smaller supported residents, like 1 or 2 people, as compared to states that are putting people in larger homes, like 10 to 15 people. We've got that. We also have some employment outcomes from a group in University of Massachusetts that's tracking whether folks with intellectual and developmental disabilities are getting employment services and are getting jobs. And so we're playing with using that data as well to try to understand some of these state differences. But this, right, just using the state of the state measure explained about a quarter of the state level variation that we were seeing in the maps early on. So there's something there. I need to play and tease it out a little bit more, but I wanted to kind of share with you some of the differences we're seeing there, but that they really are varying by race, ethnicity. Okay, I'm going to change directions away from age at death towards death certificates at this time, because this is the other real problem with doing research on mortality trends for this population. And so, like I said early on, number one, we don't know everybody within the population. We just don't have it. And so then within the US, other countries do. So then the best place to get data for health and mortality is to look at US death certificates. And I'm not going to go over just the whole slew of problems that death certificates present in and of themselves, but I'm going to focus just on the challenges that death certificates present when looking at folks with intellectual and developmental disability. And so, I mean, as many of you will know, I mean, the way the US death certificate is set up is we've got 2 parts. The first part, the person certifying the death is supposed to report the sequence of events that led to death. So the underlying cause of death, all the way to the immediate cause of death. And so whatever that cascade of events was that led to the person dying. And then part 2 is supposed to be the place where the certifier reports other comorbidities that were present at the time of death, but did not directly inform the sequence of events that were leading to death. The challenges, the extra challenges facing death certificates for folks with intellectual and developmental disability really, in my mind, and this is kind of a theoretical model I'm building, really circulate around levels of uncertainty present at the time of death. And this is a project that I've been working on and then continue to do so thanks to some a generous grant from the National Institutes of Health, where we're trying to really understand why this happens. And let me show you the problem going just initially so you understand where I'm coming from. And so what we see occurring, and this is just a severe case of diagnostic overshadowing, is in over half of the, or 48.5, so near half of the cases of folks with intellectual and developmental disability that died between 2012 and 2016, the person certifying their death certificate recorded their underlying cause of death as their developmental disability. And so cause of death would be Down syndrome in this case, or cerebral palsy or intellectual disability. this just shouldn't occur. I mean, disability doesn't cause death in and of itself. Disability might make someone more susceptible to certain types of diseases, or you might see a higher prevalence of, like I said earlier, dysphagia and leading to pneumonitis in someone with Down syndrome. But if you've got someone with Down syndrome who dies from lung infections, they didn't die because of their Down syndrome. They died from the dysphagia that caused choking that led to pneumonia and maybe the development of pneumonitis. But what we see happening is that even when that sequence of events is laid out, what the certifiers will do is then say, oh, and the underlying cause was Down syndrome. That's the event, the downstream event, upstream event that actually caused all this along the way. This is a real issue, and as you can see, there's variation by type of disability, where cerebral palsy and Down syndrome, you're closing in on 60% of death certificates record this. I mean, if you think about yes, to me, the most beneficial way to work with death certificates is to look at multiple comorbidities, but typically what's done within the public health sector is just to look at cause of death. And so if we see that as kind of a standard of trying to understand mortality patterns and trends, what we have here is a situation where we just don't know. I mean, if you look at the death certificates as reported, we don't know for about half of this population why they died, which if we're trying to address mortality disadvantage and trying to look at possibly preventable causes of death, it's just information we don't have. And so a lot of the prior research on causes of death for folks with developmental disability would do one of two things. One strategy that people have used is just throw out the death certificates that record the intellectual and developmental disabilities as a cause of death. And so all they're looking at is half the death certificates for this or I shouldn't say for this population, for those who had this disability report on their death certificate. And it's going to be biased because who was not included within the sample. The other strategy is to report the disability as a cause of death and to not drill down and say, okay, no, what was the medical cause? So a paper that we did, and I think Dalton's on the call here today, and Dalton, who's one of my grad students here at Syracuse, PhD student that will be on the market soon, and worked with me on this, is we tried to better understand the result of this. Let me show you a little bit. This is just using broad ICD chapter codes. And I wrote an algorithm to revise the cause of death on these death certificates. So what the algorithm did is throw out disability as the cause of death. And once you've done that, to look at the death certificate and try to identify what was the actual underlying cause of death. And so I used all the CDC rules for coding, all the sequencing rules for what can proceed and what has to proceed and what has to be identified and what can't be considered a cause of death, and wrote this algorithm to recode these death certificates to actually identify the underlying cause of death, the physical reason, the disease or injury that caused the death. And in doing so, what we saw is real changes in respiratory diseases and external choking deaths. And so for those with ID, intellectual disabilities, cerebral palsy, and Down syndrome, we saw, if you rank order deaths, we saw respiratory deaths bump from third to first. And the majority of this were around pneumonias and pneumonitis, and both the pneumonitis especially related to choking. The other big change we saw was in the external causes of death, and this was primarily driven by choking deaths. And so the person chokes either on food or on vomit or on some foreign objects that is put into the mouth that shouldn't be there. And these bumped up from, 5, 9, 10 in the rank order up to the 3rd through 6th leading cause of death, and had substantial jumps in 4 to 5% on these. And so what we argued in this paper is this whole practice that continues on half the death certificates, even to the most recent data, of coding a disability as the cause of death is obscuring mortality trends for this population. It's making it so if we take the death certificates at face value, we don't know why folks died. So the next part of this project, and this is what the NIH is funding, is trying to understand, okay, what are the predictors of this practice? Going down more, a little bit more to a micro level, some meso a little bit, to see, are there reasons that folks, certifiers, are engaging in this inaccurate practice? And like I said, the theory that I have going into this is that it's all around uncertainty. You know, that you're certifying the death of someone with an intellectual disability. There's a good chance that that person does not have as thorough of a medical record as someone without an intellectual disability for a few reasons. Number one, maybe they didn't have as good of access to care over time. Number two, even if they had access to care, we can't be assured that the communication between that individual and their provider was sufficient to actually document their medical needs across time. We can't be assured, for some folks with intellectual and developmental disability, that they were able to self-report their medical needs. And so maybe they've had pains and difficulties reflective of a disease pattern for 15, 20 years, but because they couldn't express what was going on, it was never diagnosed. We can't be sure that the medical records are thorough because there is still high prevalence of diagnostic overshadowing, where even when symptoms are present that should be recognized as diseases, there is the tendency for medical providers to say, oh, this is the disability, let's just move on. And so our prediction was that any of these measures that I've got in here related to increased levels of uncertainty would be predictive of the inaccurate coding of disability as the underlying cause of death. And so the assumption being, as you get older, you probably have had more interaction with the medical community. There should be more documentation of your healthcare needs. So our idea that younger folks, we'd see more of this inaccurate coding. That we'd see more inaccurate coding among racial ethnic minority groups, especially among Hispanics, because the literature documents that patient-physician communication with the Hispanic population is not as good and leads to less thorough medical records. We think there'd be more uncertainty around places of death that are further distance from hospital settings. But then the big thing, the other two big things we were looking at, or we are looking at, these studies, one's out now, two or more coming out, is looking at comorbidities, with the idea that there are some comorbidities, such as cancer that I've got in here, that increase certainty at time of death. Cancer diagnoses are typically based upon pretty good clinical empirical evidence. They're usually pretty firm. And so if someone dies with a cancer diagnosis or with cancer, if it's been recognized, it usually increases certainty within the certifier's mind of what might have been informing this death pattern. Whereas causes of death that are imbued with more uncertainty, I've got choking in here, as it's an external cause of death, and there's always questions about what they choke on, who was present, was this supposed to happen, was this just bad care, did they put something in there, someone put something in their mouth they shouldn't have. You know, there's, no matter who chokes to death, there's always increased questions. Or this unspecified category, which means that this is the death certificate included an R code, a code saying the physician thinks it could be this, but was uncertain, said, so it might be some type of heart disease, but I really don't know. The last thing that we're looking at here is some state level differences. One is the measure that I showed you before, the state of the state fundings, funding for services. The other one though, and this is, like I said, Dalton's on the call and I want to give him credit for helping me figure this out. Dalton Stevens, one of my grad students, took the time to comb through all the laws in all 50 states documenting who is and is not allowed to certify a death certificate. And he found some crazy things, like I think if you're in Kentucky, your dentist can certify your death certificate. And if you're in Alaska, anybody who's got knowledge of the death can certify it. So be careful where you die. But what we were able to do based on the original database that he built through this is to tease out, I mean, the typical US death certificate will tell you whether it was coded by a physician, coroner, or medical examiner, or other person. And what we were able to do is to tease out, based on what states do and don't allow, whether the state, the other person, was a medical extender or not. And medical extenders being the term that's used for nurse practitioners, physician assistants, folks that have medical training but are not practicing physicians. And so going into this, our premise was that medical examiners would be the most accurate, but that we'd see more inaccurate coding around medical extenders because we think physicians have very poor training on disability. Folks in this category have even less training on disability, and so we thought we'd see more inaccuracies. And so just to give you a quick overview of this, what we're seeing is what we would thought. Age is predictive of inaccurate coding. As people die at older ages, they're less likely to have their disability as their cause of death. We saw there's some noise here around race, ethnicity. There's not consistency across all three, but it's non-Hispanic Blacks and Hispanics are more likely to have their death certificate inaccurately recoded with their disability as their cause of death. Non-Hispanic Black for cerebral palsy and Down syndrome, and Hispanic for intellectual disability and CP. On intellectual disability, let me tell you, a lot of this stuff didn't show up. This was the thing that killed me. Oh yeah, I shouldn't have clicked on that. 15 times more likely to have, this was almost close to being a perfect predictor. In fact, if you tease this out by type of choking death, food choking is almost a perfect predictor. For folks with intellectual disability, if they choke on food, there's about a 95% chance that they're going to have their disability inaccurately recoded with their death certificate inaccurately coded with their disability as their cause of death. And that was, I mean, you see it was high for CP, cerebral palsy as well, but that was really what explained the majority of the difference here. None of the state level measures actually popped up significant. Different story for cerebral palsy and Down syndrome, where we see these places away from a hospital setting, away possibly from immediate access to medical records, more likely to be inaccurately recoded. We saw a little bit about the choking for cerebral palsy. But what was interesting here is that the two state level measures actually were significant, that the amount of funding states spend on services for this population actually was predictive of whether these death certificates were coded correctly or not, which makes sense in my mind because more funding is going to eventually make its way into the medical community for better training for these physicians, is what we see in the states that spend more. And then also we did find some differences by who's allowed to certify, and the most predictive of inaccurate certification was what we thought with these medical extenders. I keep clicking, I shouldn't do that. Although physicians actually were also had high levels of certifying these things incorrectly. And so this is what we're trying to do now. We put out a paper, I put one out recently in American Journal of Preventive Medicine, where we're giving physicians really clear recommendations on how they should be coding these death certificates, letting them know that the only place you should ever be putting an intellectual developmental disability on a death certificate is in Part 2, and actually encouraging them to try to get them to put it in Part 2 so that we have this accurate data and we can better track what's going on in this population, but that it should not be in Part 1. And it's not just us, it's not just folks in the disability research field arguing this. Global Burden of Disease has very openly said that these are garbage codes, that they, even if a person thinks they should have in any way, or they in any way informed the death, it does no good for anybody to put this down as the cause of death. For public health purposes, we actually need to know what was going on with diseases and things like that, so that we can look at preventing causes of death. So hopefully this line of research will give us more direct information on what situations are leading to this inaccurate coding, with the long-term hope that we can change this and get it to the point where physicians and certifiers know that if I have someone with an intellectual and developmental disability, I need to put the disability down as a cause of death, in Part 2, so that we know about the disability, but that I need to accurately code the disease or injury that caused death and not default to disability in moments of uncertainty. Jennifer, are you here?
Yes.
What am I doing on time?
You're great on time. It's 2:33.
And I'm going to 2:40?
Sure.
Okay. I'll just do just a few minutes on COVID, because that's where most of my time is going now. At the beginning of the pandemic, we kind of fired a shot across the bow to say, look, we got to be concerned about folks with intellectual and developmental disability. Put out a couple reports through the Learner Center here at Syracuse University. Based on our prior research on mortality trends among this population, we knew that folks with intellectual and developmental disability have higher prevalence of pneumonias and pneumonitis, which early on, it's changed since then, but early on the CDC was indicating could increase severity of COVID outcomes. And so we had said, we'd made the argument that because of the prevalence of these diseases, because this is a vulnerable health population, and because a disproportionate percentage of this population live in congregate settings. So around 16 to 20% of folks with adults with intellectual and developmental disability live in a congregate setting. And by congregate setting, what we're talking about is a group home, residential group home in the community that typically used to have just 4 residents. Now the average is between 6 and 15 residents live within the home, shared bedrooms, shared bathrooms, shared kitchens. And if you think about 6 to 15 residents, you're talking 20 to 30 staff rotating through a home every week. And so just like the concern with the nursing home, we were saying that especially for this population living in these congregate settings, COVID could be a disaster. It has been. Some of it is state policy, and we're tracking this. We're combing through state by state to see what policies they put in place to address and protect the well-being of folks with intellectual and developmental disabilities during COVID. It's been depressing. Like in the state of New York, where I am now, the state decided that hospitals and nursing homes would receive priority for PPE, but decided the group homes would not. Made the decision, Governor Cuomo decided that they were not healthcare entities, and so they did not get PPE prioritization. And it got to the point that, especially in and around the city, around New York City, the group home staff members in their off time were going door to door begging for PPE because they couldn't get it to go to work. And we're having drives through local churches and community events to please give us PPE so that we can protect ourselves and our residents within these homes. And so that's fortunately by around May, mid-May, early June, that had been addressed, and there was enough PPE, personal protective equipment out there. So when, like, the whole sad thing was, early April, the state of New York said, okay, people working in a group home have to wear a face mask at all times. Well, they couldn't get them. They just didn't have access to them. And so we saw this real delay in just real practical measures that could have stemmed the tide of COVID early on. There also has, and this goes back to lack of physician knowledge. I mean, discharging patients from hospitals who have been COVID positive, but aren't out of the 14-day window, so they're still able to spread the disease. Many physicians did not have good protocol and did not think through, well, this person with intellectual and developmental disability is not just going back to their family home, they're going to a group home. And maybe either didn't process or had not considered that you might need different discharge planning for someone going back to a group facility than you would need someone that can go home and stay in their bedroom. And so what we saw early on is the state telling these group home providers that you are required to bring any discharged patient with COVID-19 back into your home, physicians not working to try to come up with good discharge planning. And so COVID positive folks were being put back into the home, not quarantined because there was no money to do so, and it just spread like wildfire. The real difficulty here is that 11 states are reporting some data on COVID outcomes among folks with intellectual and developmental disability. It's not standardized, it's real scattered. The majority of states refuse to share this information because they're afraid it makes them look bad, which in some ways it does. And so trying to find data has been difficult. What we've been able to set up here is there is a coalition of providers who serve about half of the population of folks with intellectual and developmental disability in the state of New York that are living in group homes. And we've been tracking COVID trends for 35,000 adults with intellectual and developmental disabilities since early April through now. We still track every week, just looking at cases and case fatality to see what's happened over time. Our push, and I think Jennifer had mentioned this in the intro, Senators Warren and Murray and Hassan are trying to push CMS to require states to report. But until then, we're just digging. We're just trying to find data anywhere that we can. So I just want to show you real quick some of the trends that we were seeing. So this is case rate for these. The blue line is the folks who are tracking the 35,000 living in the group homes. The orange line is just state of New York for comparison, trying to see what happened. This is case rates over time per 100,000 in the population. And as you see, during this time period when there really was no PPE, state policies were confusing, providers were just scrambling to try to figure out, what do we do? What should the policies be? Even if we need care and services, how do we provide them? I mean, really you were converting and saying that group homes need to quickly become public health providers. That's what they were having to do. And you just saw the case rate explode in these group homes compared to what we're seeing in the general population. By early to mid-May, we start to see this planing out a little bit, where the group's home, and they'll tell you, I've got timelines that they've been working on me with. It's about this time that they started to have policies in place. They were doing temperature checks on everybody, 3 times a day. Everybody had a mask on. They closed down visitation. They canceled day services and really were effectively quarantine houses throughout the community. And it worked. They were able to get the case growth down. This is case growth rate over time, week-on-week case growth rate. And you can see that by mid-May, once the policies are in place, the case growth rate of COVID-19 in these group homes is now very similar to what it is in the state overall. It was awful up front. But once people had the resources they need and these staff persons had the PPE and all the policies they needed, they were to get it under control. What has not gotten under control is the case fatality rate. And this was our big concern. And this is, what's it, about 1.9 to 2 times higher, and it's staying up there. This is, we're finding across the US. I'm beginning to get data from 15 states on case fatality rates for folks with intellectual and developmental disabilities. For those living in congregate settings, case fatality rates are trending 2 to 3.5 times higher. For those we're seeing who are living either in their own home or in a family home, the case fatality rates are very similar to the general population. And so again, it goes back to what I was saying at the beginning of the presentation. Disability is not the problem. Disability is a problem. I mean, because what we're seeing, we're digging down deeper with some data from a provider in New York City, is a lot of these folks that are living in these congregate settings, the reason they're there is because they have increased medical needs. And so they've got a higher rate of pre-existing conditions. And so, yeah, it might be related to congregate setting to some degree, maybe some to disability, but a lot of it's related to their pre-existing conditions. A lot of times the people who are able to live on their own or at home are the people who have less care needs. And so they're necessarily healthier going in, and we're seeing very similar rates. But this is just unacceptable in my mind, where we're seeing these double and triple case fatality rates in the group home population. So I'll end it with this, with a call for data. I am always, always, always looking for more data on this population. There's just not much out there. To date, death certificates, National Health and Review Survey, I'm working with some state agencies. ACS has got a measure on cognitive impairment, but it does not differentiate between lifelong disability and age-related impairment. So in my mind, in some ways, it's useless when looking at this population. But if you're not interested in working in this area, if you're interested in working in this area, please jump in and go for it. But if you're not, and you ever come across any type of data that's got a measure for intellectual and developmental disability, please shoot me an email, because if it's one I haven't heard of, I'd love to look into it and see what else is out there. So I will stop there and take any questions.
Terrific. Thank you, Scott. It's not the first time I've seen parts of that presentation, but I never get tired of hearing it. It's so fascinating. So you can see the chat box, or am I the only one that can see the chat box?
Oh yeah, I got it.
Because I can read them to you if you prefer. So anyone who wants to ask a question, please type it in the chat box, or if you prefer to ask your question verbally and want to be seen as well, we can make that happen. So I know sometimes it gets tiring to type a long, complicated question. So if you have one of those questions, just type in the chat box, please let me ask it verbally and we'll make it happen.
I'm going to answer Bob's question. So he's asking whether there are any large-scale surveillance studies on this population, kind of just going through all pieces of data available, obituaries, next of kin, medical records. To date, no. They're not in this country. It's a great question. In the UK, yes. Pauline Heslop is at Lancaster, and she actually got some NHS funding and has done, not to the detail you're talking about. She's not, I don't even know her training. I think is in disability studies. But she is trying to put together an overall kind of surveillance picture of health among this population. She's really, it's interesting, she's having trouble from some of the primary care providers that while they're willing to register people and get them on the books, their follow-up on the health records is really causing her difficulty in this project. So I think there's hope that we'll have some of that in the UK. It'd be interesting how we piece that together in the US. I spent some time, Bob, looking at obituaries, and that's the whole thing that's tricky, is how you identify intellectual and developmental disabilities in obituaries. I mean, if you look through I went back pretty far. If you look through like the 50s and 60s, it will actually say, so-and-so had mental retardation. And then we had this real transition, if you look at the obits in the 70s, where it doesn't say that anymore, but it would say, so-and-so loved to participate in Special Olympics, which is kind of the key word that people started using. But then now, if you look at obituaries of folks that died with intellectual and developmental disability, a lot of times it's not even mentioned at all. And so I think there could be the possibility. It'd be worth talking about, how we could maybe strategize doing that. It's a great question.
So Scott, we had a question come into the Q&A box from Andy Finalen. So I'll just go ahead and read that one. It's very related to Bob's. So Andy's asking, what sorts of data linkages don't currently exist, but could help a lot if they did?
Yeah, Andy, it's a great question. I mean, I think, my hope would have been there was the chance with ACS that they were going to ask an intellectual disability question. I think it's still on the board. And so if we could get that question within the ACS data, that'd be really helpful. I mean, we've got the linkages with the NHIS and the NDI that are good to look at for mortality outcomes. It's still such a small population, but it's enough I've been able to do a few studies off of. I'm trying to think, like in a perfect world, what linkages will be. I mean, I think the big thing would be with the whole thing, and this is what's killing me. CMS has got this data. And they've got it in such a way, I mean, I've seen it before with working with folks there. They have the ability to identify everybody receiving some type of Medicaid waiver services, which majority of services these days are Medicaid waiver. They know who's receiving it, and they have access to medical records for these folks, but they refuse to share. So Andy, I don't know that it's much about what linkages would be helpful. It's about what organizations would have to get on board and be willing to share their data in order to actually give access to it. And to date, there's just not been that level of cooperation. It's really protected. They really protect that data pretty carefully. I've got another question on the chat here. Yeah, so the question is, Dalton was asking how disability is distinct from impairment in health in the context of death certificates and cause of death reporting. I mean, it really depends on how you define disability and how you define impairment. I mean, the whole challenge and the whole bias you would see within this research is the only way that we're able to identify disability on the death certificate at all is through an ICD-10 code. And so if for some reason that's not on the death certificate, there's just no way to tell whatsoever. I mean, don't, it depends on how you're defining disability impairment. I mean, so I'm taking the ICD-10 code um, as representative of the disability category. There's no way to tease out really level of impairment with the death certificate. I mean, there's no further coding. I mean, like if you've got someone that's got an ICD-10 code for Down syndrome, you don't know the degree of disability, how severe that was, or I mean, whether they were someone who was able to work and function within the community, or whether their Down syndrome was so severe that they were in bed their entire life and using a feeding tube. And so unfortunately, and you just can't tease that out with the death certificate. So it's another limitation of the data.
Scott, I have a question about the American Journal of Preventive Medicine article, I think it was, where you said that you had made some recommendations on how to correct
Yeah.
The cause of death coding. What kind of reaction have you received from that? And what is your plan to make this more public and potentially, you know, standard?
Yeah, so that nothing yet because that drops on 11/11 on Veterans Day. So yeah, that's when that comes out. So that's I mean, good question, Jennifer. We really lay out clearly, give the examples of the problem, but then lay out kind of the steps that certifiers need to take in order to do this correctly. I mean, how they need to code it, where it should code, things like that. You know, the plan that we've got is we're actually working with Bob Anderson at the NCHS and in talks with him because Bob is on board in recognizing that this should not be occurring, that disability should not be allowed to be identified as a cause of death. And so the next steps we're taking are in consultation with him is trying to see if we can have, I mean, the whole thing is the CDC rules for death certificate coding still allow the disability to be identified as a cause of death. And they're obviously influenced by the WHO rules. Bob originally was saying, well, it's going to be important to wait for the WHO to change that. But I think he's maybe come around to the idea that the CDC could put in place standards and release it to certifiers stating that this is just not allowed anymore, that you can't put this down as the cause of death. That's one strategy that we're taking. Another strategy that's just come up more recently is we're looking at actually, and this is new to me, working with some engineers and computer folks to use AI to try to come up with an algorithm that certifiers could use in their coding process that would hopefully lead them away from actually identifying disability. A lot of it, Jennifer, is going to be around training. I mean, you've got to get down to the ground of the medical provider and help them understand. And so I think we really need to be able to put policies in place, but a tool in hand where they can say, okay, if I can't put it there, where do I put it? And what do I do in these situations where I don't know anything but that they had a disability?
So Janet Wilmus submitted a question through the Q&A, and I think that you've answered most of it, but there's one part of her question that I think still would be great if you could comment on, and that's around, you know, who should be doing this? And I'm also, this reminds me of, I can't remember who produced this documentary, but it's called Postmortem, and it's about how, you know, death certificate are just, you know, inaccurate, you know, for everybody. And it was really, really shocking. And I show it in class whenever I can. But I remember in that video, what was so striking was that, yeah, in some states, just about anybody can certify a death certificate or write the cause of death. So, I mean, do you see that as still being problematic, that anybody can certify it, or that there's a range of people who can certify it? Is that still problematic if the training is very specific, or if the protocol is very specific?
Great question. That's our strategy. If we can get it to the point where this is just not allowed, so that even when, I mean, what you would want is that for the CDC coding to be in place, that once the death certificate makes it to the point that they're entering the data, I mean, because you already have that going on where the nosologists are having to kind of readjust the causes of death on some of these. If you could get it so there's a stopgap that flags these death certificates that code this incorrectly and say, okay, these have to be revised, formally revised, and on the other side need to come out without the disability as a cause of death, then I don't know. I mean, I think it would be still important to train people to reduce the amount of inaccuracies going on, but that'd be the stopgap. I think you're going to have to do both, though, to actually ever really take care of this, because the whole difficulty is by the time you get to the person who's actually revising these along the way, they're not going to have the information to the immediate medical record that was present by the certifier. And so while we might be able to prevent the disability from being coded at that point, you're not going to be able to go back and say, okay, but what else was going on that you just didn't even bother to put down because you defaulted to the disability? So in my mind, we've got to hit on the front end at the person doing the certification. I'm not necessarily personally against states having different policies on who's allowed to certify. I think we've got to have, and this is for all death certificates in general, I think this is probably, anybody could say this, there's got to be increased training, though, among medical personnel regarding disability, to be able to recognize it and to know what to do with it when they've got someone in front of them that has a disability. And Janet, I think, you ask who's responsible. Janet, I think you are. Is that a good answer? Can I put that on, Janet?
So we have another question from Carmen Gutierrez, and this is also coming through in the Q&A box. I'm not sure if you have that popped up. If not, I can read the question. She's got a couple of questions here. Maybe I'll just read it for the benefit of everybody. She says, I have two questions. One, I'm curious if you have had a chance to disaggregate the non-Latino Asian population in your findings. It strikes me that there might be variations within the group by nationality. And then her second question is, I'm wondering if you have noticed any overlap between the IDD community and people who become incarcerated in jails or prisons. I wonder if there might be data opportunities in the health information collected among people who are incarcerated.
Yeah, so Carmen, your first question, great question. That's what I'm doing right now, is trying to see how fine grain I can get on race, ethnicity in this death certificate data. Because like I showed, there's definitely something going on among the non-Latino Asians. It's a matter of how deep a dive I can get. And a lot of it's going to be case size. I mean, I'm already got together, we've got 15 years of data now just to make sure that we have enough cases. It's going to be, are there enough cases per category? So hopefully we'll be able to dig down deeper, and I can get back to you on that one within the next month or two. But it's a great question, because I think you're exactly right. I think different ethnicities, there might be different results, not just, I think based upon history in the US, based upon access to care, but also based upon cultural differences, because different cultures see disability differently. There are some cultures that have been very open to it and very open to receiving supports. There are some cultural groups that it's really a struggle, that to have a child with a disability in some ways can be very challenging for the family, and it's sometimes easier to not get the help than to get the help. So I think that's a great question. The overlap with the jails incarcerated is strong. I mean, the big overlap is between IDD and mental health. Just the comorbid occurrence of that has been on record for years. And a lot of times within the IDD community, when you have the combination of IDD and mental health problems, a lot of times it can lead to incarceration, not necessarily due to fault, but due to the service system not knowing what to do with folks. I mean, so they're not doing well in the community, they're not doing well in the institution. Well, jail sometimes ends up being the best place, because you can always get some for misbehavior. I mean, we see that repeatedly within some of the police reporting, where someone gets called out for mental health problems, they have an intellectual and developmental disability. The officer who arrives on the scene can easily lock them up for, causing some type of commotion, things like that. So I think it's a great question. It's not something I've looked into, and based on what you're saying, I think I need to see if we can find any data among the incarcerated population on IDD. I've never looked at that. It's a great question. So I will look into that.
And you have a question that just came in from Sarah Brigard in the chat box.
Recommendations for those of us measuring social, don't you read this? Sarah asks, recommendations for those of us measuring social disparities in morbidity, say diabetes. accurately, not just mortality, and understanding how to capture differences for the IDD versus other communities. So that's a great question. I mean, obviously if you have any type of measure within your data that you can identify IDD, that'd be the easy thing. There's you can look at comorbidities present at the time of death. I mean, it's not the most accurate understanding of comorbidities, but I mean, it does give some idea of what's going on. And diabetes is an interesting case because we just showed in a recent paper that among folks with intellectual disability, those with severe and profound levels of intellectual disability, so lowest level of IQ, their causes of the comorbidities present at the time of death were mainly respiratory, the pneumonias, the pneumonitis, things like that. But folks with mild levels of intellectual disability, we found higher prevalence of diabetes, especially early in life. And the theory behind that is group home settings are high carb, high fat diets. You don't get to prepare your own food. You don't get to exercise much. And so you're seeing these spikes in obesity and diabetes. But beyond the question, I've not dug into this, is there's about, if you the 86 through 2017 NHIS, I mean, that's what I've played with. I mean, if you put those files together, you get about 4,000 cases of folks with intellectual disability. I've used it more for mortality, but I mean, if you're in that data, you've got the measure there. And if you're using that data, you could probably tease out, are there differences in some of these other comorbidities that are included in the NHIS? Do they have diabetes? I've not even looked in the NHIS. And so that'd be a way to look at that. Yeah, that'd be really intriguing. The other good thing about the NHIS is the disability measure there, they give you duration. I'm not going to speak to the accuracy of it because I've looked at it a couple of times and there's some real anomalies within it. But for, I think, a sizable part of that 4,000, you could look at duration, onset, and then maybe look at how that's affected comorbidities. Yeah, it's not something I've gotten into because I tend to be so enraptured with death. But yes, I was talking to someone the other day and he was like, Scott, land of the living, come over to this side. It's like, yeah, okay. But I think
I think based on
it's
what you
part of the
said, it's
story.
changed too, because if ADHD and other, there are big cohort shifts in stigmas around these and in diagnoses of these and so forth, it's going to create some really interesting stories going forward. Thank you.
Yeah, and I think the other thing, Sarah, because mentioning ADHD, is the kid data is there. I mean, if you look at the NHIS child data, you've got Down syndrome, you've got CP, you've got ADHD. I've just never done research on children. And so if you ever wanted to jump into the child data, it's rich. And I think it'd be much easier to do that with the child data in the NHIS. And plus you've got a more sizable population. Probably more accurate too, I would think. Yeah, it's a great question.
Well, it's 3:01, so we'll have to stop the Q&A, although I have many more questions, but Scott, I will see you in the hallway someday soon.
That's right.
Let's hope. So thanks everybody for joining the November session, and thank you, Scott, for a really engaging talk. That's just, your work is so compelling. I love the way you present it. And, maybe we can think of, like Scott said, if anybody can think of, creative data sources, other ways to study this population, please reach out. Let Scott know what you've uncovered. But again, Scott, thanks. This was super. We're going to put this on the network website. So if you want to listen to the talk again or share it with one of your grad classes, it's there. So we'll see you next month on December 4th for the next network session.
Thank you.